So Pete talked a little bit about labor and delivery, and I just kind of want to coattail on that for a couple of reasons. One, I think this kind of naturally falls kind of the next reasonable topic after labor and delivery and precipitous delivery and complications. I think the most reasonable next topic is neonatal resuscitation, right? And number two, we kind of had a rash of them this spring, and I've been meaning to kind of go over some of the newer guidelines and just refresh this, because it's definitely a low frequency, high stress circumstance. And we have cases in here that we're going to review later on towards the end of the lecture. And fortunately, most of the players that were involved in those cases are here. So it's anonymous, but if you feel like revealing your identity and providing some insight, I'll leave that up to you. But we're going to kind of look at them after the fact and use them as a teaching tool to maybe make life a little bit easier on your colleagues who get picked for the next low frequency, high risk event, okay? So, what are our objectives today? I want to just talk briefly about post-delivery care of the infant. So leaving off that baby spits out, what's the most appropriate thing to do with that baby? Now the focus is not on the mother or the delivery process, it's on the post-delivery process, okay? We'll talk about heart rate assessment, oxygen administration. We'll talk about advanced airways when they're indicated and what your options are. We'll talk about CPR. We'll talk about medications, which are really a very few that are indicated in neonatal resuscitation. And then we're going to review a couple of cases, okay? We may not make 2 hours out of this, okay? So I brought some stuff here, so we'll take a break in a bit. And it'd be good for everybody to kind of, and truthfully, you could probably just start passing this stuff down, spread it out while we're talking, do stuff, and during the break, work on stuff. So yeah, just start passing the baby and the IO. And if anybody who's a kinesthetic learner, sometimes it's better just to have it in your hand while you're learning about it. Okay? Does this mean I have to be filtered in my language? Because I can't guarantee that I'll be filtered in my language with a, just kidding. So, post-delivery care, 3 questions. Am I term gestation? Do I have good tone? And is the baby breathing or crying? Okay? If I have a term gestation infant, I've got good tone, and the baby's crying, you can pretty much relax. Okay? I mean, you're going to still be amped up, but you can focus on, all right, let's get all of the vernix off of this kid, right? We'll just dry him out. That's your biggest goal. Dry him, keep him warm, right? If I have a preterm kid who's flat and limp and not crying, well, now it's time to get ready, right? It's time to get into gear, get focused, because you're going to be required to do things. Fortunately, with neonatal resuscitation, it's high anxiety, but the vast majority is going to respond to airway management. And not invasive airway management necessarily, just ventilation assistance, okay? We got a couple of cases of that. And they break it down into the golden minute. That first minute, you should be able to get a good assessment and have a plan in place. And by the end of that time, traditionally, you'll have your first APGAR, right? Because we take our APGARs at 1 minute and 5 minutes. So you've got 60 seconds to complete your initial assessment, which is these 3 questions, okay? You've got time to do your immediate post-delivery care and reevaluate a kid in that time. And most importantly, if you need to initiate ventilations, you're doing it within the first minute, okay? So your first criteria or your first intervention, critical intervention of ventilation, should not be delayed beyond 1 minute from that kid leaving the birth canal, okay? And it's going to be based on term, tone, and vocality, essentially, okay? So here's our traditional APGARs. Don't ask me to recite these. I'd have to look at a card and cheat and find the little thing that tells me exactly what they are. But they're essentially the same thing as what do I see when I walk in the room, plus the only vital sign you have is a pulse, right? So what's my appearance? I'm blue everywhere, I'm blue only on my extremities, or I'm not blue at all. You can pretty much leave this guy out because almost every kid is going to have a little bit of cyanosis. So essentially, a 9 equals a 10. I've never seen a APGAR of 10, okay? I haven't delivered tons of babies, but the ones that I have delivered or seen or participated with, they all have blue feet, right? They all got blue little hands. So they all get a 9 at best, and everybody celebrates because a 9 is a 10, right? It's like lax grading in modern education, right? A 9 is equal to a 10, okay? Didn't even earn it, but you got it. I shouldn't say that's terrible, right? It's the millennials. Just kidding, guys. Relax. So appearance, pulse, right? Am I no pulse, less than 100, greater than 100? Grimace, what do I respond to stimulation, and what's your stimulation going to be when you pull that kid out? You know, you get the pictures of the little hand smacking them on the rear end, right? We're not holding babies up and smacking them on the rear end anymore. Stimulate, smack the bottom of the foot. Drying them off in and of itself should be enough stimulation to make a kid cry, okay? Activity, are they moving? Are they vigorous? Which is good, right? A kid that's moving all extremities and crying is a vigorous kid. If they're limp and no tone, that's bad, right? And then breathing. They have a good, strong cry. That's the best indication of good breathing. Have you ever seen grunting in a newborn? They kind of, that's how they breathe, right? My son did that when he came out, and I was like, you know, wringing my hands. It's like, come on, buddy, just cry. And after that, I don't want to ever hear you cry again. But at least right now, cry. But that would be considered weak or slow. So that'd be, what would that be? 1 point, right? So you can have 10, but nobody gives a 10, so 9, right? If you're better than 7, you're normal, or 7 or better, you're normal. 4 to 6 is low, and critical is less than 3, okay? But this is a what do I see when I walk in the room type thing, right? I mean, other than the fact that you're going to try and get a pulse, but I'm going to be honest with you, we're really good, and we'll talk about this, we're really terrible, I should say, about getting an accurate pulse, okay? And we'll talk about that. So, post-delivery care, immediate post-delivery care. There's a lot of evidence to say, look, if I got a healthy kid that's not going right into resuscitation, then you can delay clamping, right? It doesn't have to be done immediately. You can delay clamping, and there's some evidence to suggest that young, healthy, term infants actually did better when they weren't clamped immediately, okay? So you can do a lot of the stimulation on mother's lap or belly. You can do a lot of the stimulation, your initial assessment. You don't have to ignore the kid to cut the cord, right? That can be done somewhat delayed. Now, if I got to take that kid away to resuscitate them, they're kind of tethered there. So in those cases, cut the cord, get them to where you can work them, right? You want to be at least 4 to 6 inches from the umbilicus, okay? Try and give yourself a nice, clean cut. And we'll talk about umbilical catheters, which most people don't have the correct equipment to even do it. But in a circumstance where you might need to resuscitate somebody and you feel the need to call medical control and say, hey, look, I've got an angiocath and I think I can get an umbilical catheter, it would be nice. Or if you call in and they say put in an umbilical catheter, you ought to know how to do that, okay? So we'll talk about it. In the advent of the IO era, that really should never be an issue, okay? Because most everybody's got IOs that make that extremely easy. Temperature management is a real important factor in this initial minutes of post-delivery care. And it is a predictor of morbidity, okay? So very important. Our target is 36.5 to 37.5, which is essentially, what's the conversion? It's like 97 to 98 or 99 or something like that, right? 96 is, or 36 is like, less than that's hypothermic, right? 38's a fever, so you want them right in that normal range. The most common thing we do is dry swaddled with warm blankets and head covered, right? That's what you get. You get your little nice cute cap and a nice cute little striped blanket in the hospital, and you get all, but you don't always have that in the austere environment, you could say. So alternative options are skin to skin. If mom's warm and you can cover mom and baby, mom will warm up that baby, so put them skin to skin. Particularly in neonates, you can use food-grade plastics. This is another good trick for burn patients, is that you can use plastic as a barrier. So food-grade, hence the bag of food right there. So you can use a food-grade plastic, which includes saran wrap, and you can wrap them in that to hold, essentially to prevent evaporative losses is what it does. Okay, and then bundle them from there. And then anything you can get for warm. In one of the cases we'll review, the kid's placed on a warm. It was a warm blanket from the IV warming something. They found something warm and put the kid on it. We'll talk about that. And then the next thing is clearing the airway. And a lot of clearing the airway depends on meconium stained versus clear amniotic fluid, right? And everybody wants to do what when they deliver that kid? What do you want to do? Everybody wants to bulb suction that kid, right? And I'd say that is one of the newest changes, is that is not necessary and actually may lead to bradycardic episodes because of a child's heightened response to vagal stimulation. Okay? So there are indications to do it, but it is not part of the routine delivery of a kid. Okay? So I hate to say it's not all black or white. There's going to be instances where you're going to want to do it, but it is not routinely recommended. It's only indicated if an airway appears to be obstructed or if positive pressure ventilation is required. So if I have a kid who's failing, not breathing, not crying, it appears to be contaminated, and I do have to clear the airway, we'll do it. But a kid that's just kind of coming out of the birth canal, the first thing you do is drop the kid to get your bulb syringe so that you can suction them, right? Don't worry about it, okay? And the vast majority of these deliveries, you're not going to need the bulb suction a kiddo, okay? You want to know whether or not we have meconium-stained amniotic fluid. And this is the vernix, right? It's that kind of greasy, it's actually greasy, I don't even know what the way to describe it. Waxy, yeah, waxy covering that's on these kiddos. It's hard to peel it off, right? It's hard to get it off of there. It's usually white or cream colored, right? If you don't see the fluid, but someone hands you a baby and they've got green vernix, that kid was delivered into a meconium-stained or delivered in meconium-stained amniotic fluid. And sometimes their umbilical cord will be stained green. Instead of that nice cream-colored umbilical cord, it'll be stained green, okay? And that's meconium. And what's meconium? Poop, right? Just, they're ready to be out of there, right? Everything's working, and when it starts working like that, you don't do well in a closed container, right? So meconium staining, they used to say that intubate those kids and suction meconium, right? You suction them out if they were delivered through meconium-stained amniotic fluid. This is no longer recommended. We will recommend intubation in the setting of an ongoing resuscitation, but meconium-stained fluid does not mean intubate this kid and perform tracheal suction, okay, as it used to. So there's two changes from probably what some of you recall or remember, and even what was being taught to me when I initially learned neonatal resuscitation, okay? So two changes right there. One is we're not using the bulb syringe as readily as we once were because of the vagal effect. And two, there's been no benefit, not necessarily that it's harmful other than the harm that comes from procedures like this, but more importantly, there's no benefit in terms of outcome in these kids, okay? What you should be aware of, though, is that meconium is a pretty good indicator of fetal distress, okay? So when I see that, not necessarily that I need to tube them, but I should be a little bit heightened in regard to how aggressive am I going to need to be with this kid, right? How vigilant do I need to be in terms of this kid failing later on down the road? Does that make sense? Heart rate assessment. So this is one of the APGAR scores, right? And we guide resuscitation effort based on heart rate. The problem is that we do a very poor job of getting an accurate assessment, okay? Auscultation, pulse oximetry, an umbilical pulse or a palpated central, usually brachial pulse or femoral pulse. They're notoriously inaccurate. And even pulse oximetry has been proven to be a poor correlator to an actual true pulse. So what happens is a lot of kids get over-resuscitated that didn't need it. So their pulse oximetry says 50, but they're really above 60, so you never had to start compressions, right? So, and that's been well documented. So the recommendations are that we should be using 3 leads as much as possible because they're far more reliable and they're readily available. Now, our stickers are gigantic stickers, right? So it's going to be like pop, pop, and pop. So I got one here. It's going to be like dinner plates, right? But that's better than trying to use pulse oximetry, which on a cyanotic hand, right, or a cyanotic foot, is probably going to be poorly accurate as it is, okay? Does that make sense? So go to your 3 lead more readily than you probably have in the past, okay? You may have trouble with them sticking because of the vernix layer, right? But knowing that that's probably going to be your most reliable indicator of heart rate. And one of the other things that's important is that your heart rate recovery is your best indicator of successful resuscitation. I know that sounds kind of obvious, but when I got a kid that looks like crud and I've initiated ventilations with the vast majority of how am I doing? Am I making progress? So am I going to have to tube this kid, or am I going in the right direction with ventilation? Heart rate recovery is going to be your best indicator to, yes, let's keep ventilating, or no, let's go for a more definitive airway because I'm not getting the kind of response that I want. So you want that to be accurate. Does that make sense? Okay. Oxygen administration. Your initial oxygen concentration should remain low. And whenever possible, if I'm going to BVM and assist ventilate somebody, room air. Okay? Particularly in the term infant, room air. If I do have to supply some supplemental oxygen, particularly in the premature patient, then I'm going to use low FiO2, so blow-by, right? Or mixed oxygen. I want a low FiO2. Particularly their central nervous system, retina, brain, is extremely sensitive to oxygen-free radicals, okay, and oxidative damage. So what our target is these goals right here. So a minute after birth, my target preductal SAT is only in the mid-60s, okay? So really, a pulse oximeter is not going to do me a whole lot of good. And if I'm used to resuscitating adults all day long and I see a SAT of 65, what's your instinct? O's. 65 is bad, right? 100% FiO2. I want them up 94 to 98 or whatever, right? I want them up in the 90s. I don't want that for these young kids. They're not built for it, right? They just went from fish to land mammal, right? They went from underwater mammal to land mammal. And there's a little bit of time of transition there, and you got to get them the opportunity to get up there on their own. And that'll take 10 minutes. So by the time you drop them off, they're probably going to look like what you want them to look like. But while you're initially starting your resuscitation, don't get caught up with a hypoxic neonate, okay? Heart rate recovery is going to be your best indicator. Remember not to rush to excessive SpO2. Our protocol has this exact chart in it, okay? So that you can reference that if you need to, okay? Does that make sense? Okay. Now, we do kick up, well, we'll talk about that in a bit. Again, in general, 65% or more should be avoided in your initial resuscitation effort. Now, if I have a little kid who I'm working on ventilating, I'm not getting the heart rate recovery, their SATs continue to be in the 60s even after 10 minutes, and I'm still trying to work this kid, then I'm going to start increasing my FiO2 to meet those targets. But I want to avoid at all costs going up to 100% FiO2. Okay? And even in the setting of intubation, let's say we move the compressions, at which time if I move the compressions, then I can go to 100% FiO2. But as soon as I get pulses, we're titrating that and weaning it back down. Okay? Does that make sense? So it's almost think of it like our strategy for optimal sequence intubation, right? I'll go to 100% just to get through that initial period of resuscitation, and then I'm back down as soon as I get pulses back or I get to my target resuscitation measure, okay? Does that make sense? So remember, what are oxygen? We talk a lot about oxygen-free radicals. Here's a normal oxygen atom. When I lose this electron, because oxygen is notoriously an unstable molecule, right? So I pop this little electron off, and I end up with a free radical, okay? And free radicals cause oxidative stress. So a good joke to tell your science buddies is you got two atoms walking down the street, right? One of them says, stop, hold on. I just dropped an electron. The guy looks down, they're looking all over the place. You sure you dropped it? I'm positive. Right? Okay. Don't remember where that one came from. Stick to medicine. Come on. It's my warm-up. My warm-up for stage comedy. Sorry, guys. You don't have any science friends? Is that what it is? Come on. Sitting in a room full of them. All right. So advanced airway management. Positive pressure ventilation. We want our initial effort is going to be 30 seconds at 40 to 60 breaths per minute, right? This is, you've got it, with this population, we have reinforced the importance of perfusion. Slow down your ventilations. Ventilations kill people in resuscitation. Don't hyperventilate, right? Now it is the exact opposite in this population. The vast majority, because almost none of these are going to be primary cardiac arrest, right? The vast majority of them are going to be respiratory arrest. And it's ventilatory support that's going to turn them around, okay? So this strategy of don't compromise compressions by overventilating is just the opposite. I don't want to compromise ventilations by anything, okay? So my initial effort is going to be 40 to 60 breaths per minute for the first 30 seconds, okay? And what I'm going to do is I'm going to look for that heart rate recovery during that time, right? The vast majority that are failing or in that low APGAR score or concerning picture, when I looked at them, they were preterm, had poor tone, and a poor respiratory effort. most of them will come around with ventilatory support. Okay? Got it? And I'll see that initially. Now, if I'm going into prolonged ventilatory support beyond this, where I think I'm going to be at it for more than a couple of minutes, then I can go into more advanced airway. Okay? There's this concept of what's called sustained inflation, particularly in the beginning, where you actually give a slow, instead of delivering quick bags, your first several, and I've never done this, but it was in the AHA guidelines and there was a lot of recommendation for it, is your first several should be 5 breaths of about 2 to 3 slow, and they say target 30 centimeters of water, which I don't know how to target 30 centimeters of water, but it's kind of a nice, slow, steady insufflation with an effort to open up some of that atelectatic lung. If that's even a word, I think it is. You want to open up some of that lung. You want to increase your functional residual capacity of the lung. Remember we talked about lung volumes. You've got your vital capacity, functional residual capacity, your tidal volume, which is what we generally... Well, if I want to increase my functional residual capacity, I got to open that stuff up, right? And this sustained inflation or sustained insufflation can be initial strategy in the very beginning to maximize that, as opposed to just your fast tidal volume breaths. Okay? So consider that early on, remembering that I want to target this, though, at 40 to 60 beats per minute, okay? Or breaths per minute. Particularly in preterm infants, PEEP can be beneficial for that same effect, right? I want to open up this immature lung. In the hospital, they'll actually add surfactant, and they'll put surfactant down the ET tube. We don't have that, but you really want to kind of open them up and get them ready to be utilized, okay? Your eye gel, there is a size 1 eye gel that is appropriate for greater than 34-week preterm and term infants, and can be considered as an alternative if your endotracheal intubation attempt is either unsuccessful or unfeasible. And we have an eye gel size 1 going around with the mannequin, and I would take it out and look at it. It looks like it belongs in like my daughter's play toys with their dolls. I mean, it's a tiny little thing, right? But try that out and get used to it, because you may rely on that on a failed intubation, okay? Or in a standard resuscitation where you defer the airway to somebody else, put in an eye gel, okay? So it's something different that was not available with the King Airways combi tubes and other supraglottic devices, essentially. But this is fit for the infant, okay? So an alternative airway for the infant. Endotracheal intubation, when is it going to be indicated? If I've got an ineffective or prolonged bag valve mask effort greater than 2 to 3 minutes, then I should consider going to a more long-term management strategy, which is going to be secure an airway, okay? If I'm doing chest compressions on an infant, that's an indication for advanced airway management, okay? If I am suctioning a non-vigorous infant, and this is the time when we do suction kids that come through amniotic fluid that's stained with meconium, the language is a non-vigorous infant delivered through meconium-stained fluid, that's an indication for intubation and suctioning, okay? So not just any kid coming through meconium, but only the non-vigorous infant, right? And what is non-vigorous? It's the eye test, right? What do I see when I walk in the room? Non-vigorous is poor tone, no cry, bad color, right? It's when you get the pucker factor, right? That's non-vigorous, okay? Very premature infants. CO2 is going to be our most reliable confirmation, but needs to be paired with other clinical indicators of success. Ideally, I want to see this pass through the cords, right? I want to see fogging in the tube. I want to have absence over the stomach. I want equal breath sounds. I want chest rise. I want all those features. I'm still going to get end-tidal CO2 whenever possible. It's going to be hard to add that device to a tiny little 3.0 ET tube thing, but use it. It's going to be your best indicator of success. And maintenance. Remember, this is a tiny kid with a big head. His head starts flopping around, right? You have a good likelihood of dislodging a tube that doesn't have a cuff in it, okay? So it is a good indicator of maintenance of that airway as well. Chest compressions. When we start chest compressions, heart rate's less than 60 beats a minute, okay? So bradycardia, not PEA, not asystole like in adults, bradycardia. Bradycardia, less than 60, gets chest compressions. The best technique is the two-hand encircling technique, thumbs over the lower third of the sternum, hands circling the torso and supporting the back, and giving compressions and ventilations in a ratio of 3:1. And I want 1/3 the diameter, okay? That makes sense? And it's going to be in this pattern. Compression, 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 breath, compression, 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 breath. And this is going to be at 120 events per minute. So I want 90 compressions to 30 breaths, okay? I don't want to stack them. So your timing is going to have to be paired with somebody, right? So 1, 2, 3, breathe, 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 right? Get that? I don't want to impair my ventilatory effort by compression, which is exact opposite of what we say in adults. Don't impair your compressions by ventilations, right? Totally the opposite here, okay? So pair those and synchronize them, and it's going to take good communication for whoever's on that mask or whoever's on the bag and whoever's doing compressions, okay? I think in the setting of our pit crew design, I think this, we target 100 beats per minute, and we target this kind of synchronized event with adults. I think that, even though it doesn't specifically address neonatal resuscitation, I think that environment is more conducive to a successful neonatal resuscitation. And so I would say just take that same strategy and improvise where you need to, but keeping in mind the fact that it needs to be a synchronized, well-communicated process, okay? If you think that the arrest is cardiac in origin, and a neonate is up to 1 week after delivery. So you get called to a house 4 days post-delivery, and you get a kid who looks like it's cardiac in origin. You put they got a wide complex tachycardia, they got some sort of congenital heart defect. Then you can go to a 15-2 pattern, okay? But in general, I would resuscitate it at 3:1, okay, in neonates. And if I do initiate chest compressions, that is when I crank up the FiO2 to 100%, okay? But as soon as I get heart rate recovery, that drops back down. And as soon as I can get to room air, I'm going to take it to room air, okay? Any questions about that? Okay, epinephrine. Persistent bradycardia, less than 60, right? Pulselessness despite adequate ventilations, consider epinephrine. 0.01 to 0.3 milligrams per kilogram, IV or IO. Okay? You're probably going to have an IO. It would be really difficult to get an IV. Volume expansion, 10 cc's per kilo. Okay? So 10 cc's per kilo boluses repeated times 3. You guys have heard me say a lot that if you're giving volume resuscitation, give it fast, right? Give a fast bolus. That's the best way to gauge whether or not someone's volume depleted or not, right? It doesn't go so well in pediatric or in neonates, okay? So this is where I would say a slower infusion is more important, because there is evidence, good evidence, that rapid infusion can contribute to intraventricular hemorrhage, okay? Which is not uncommon in the neonatal population, okay? Glucose, there's no guidelines in the American Heart Association for neonatal resuscitation. There's no guidelines for glucose administration. Our protocol is that if we have a glucose less than 40, then we're going to give a diluted glucose, okay, at a 1 milligram per kilogram volume. And you can take your D50 and make it diluted to D25 by a 1-to-1. Okay, so if I got an amp, if I got 50 cc's in an amp, and I have a 100 cc bag of fluid, right? Then I pull out 50, waste it, and put the glucose in. Now I have D25. Okay, that makes sense? Or spit out half of your D50 onto the floor and fill the syringe back up with saline. Now I'm D25. Okay, and then you're going to take your sample from that. Okay, make sense? Narcan, not routinely recommended for resuscitation of the neonate. Okay, you can deliver Narcan in neonates or in infants, and the dose is, I want to say it's like 0.1 milligram per kilo, 0.01 milligram per kilogram, 0.1 milligram per kilogram. I'd have to look it up. Was it 0.1? 0.1 milligram per kilogram in an infant? Yeah, that's what the Broslo tape is for. And there are circumstances where I might say this is not a routine resuscitation of a newborn, as we will discuss in one of our cases tonight or today. Okay.
So why not D10?
Because it's really hard to make D10 out of 50. I mean, you could dilute it like 5 times, but if I take 25 and then I dilute 25 again, then I have D12 and a half, and that would be about the closest. Unless you have D10. Then you can give D10, and a lot of time in the hospital, they'll resuscitate infants with D10. It's just a slower, gradual volume or way to correct it. So D10 is common, but just less practical in the pre-hospital setting. It's common in the hospital. Good question, though. So if I'm going to administer meds, then I'm going to do it one of 2 ways. I'm going to either do an IO, which is probably the most likely, and it's your traditional sites with a small neonatal IO, right? Or if you are asked to, or you have no other option, and you get medical control approval, because it is not in our protocols for standard IV access in a neonate. But I think it's important for you to know how to do it and how the anatomy makes it successful in case you get into a dilemma where someone asks you to do it. So if you look at the umbilical vein, remember umbilical circulation, this umbilical vein ties into the portal system essentially and dumps into the inferior vena cava, right? This becomes a ligament. And you can see it in the operating room and surgery. This actually becomes a scarred out old ligament that sits in the anterior abdominal wall, on the anterior surface of the peritoneum, just inside, just on the posterior surface of the abdominal wall. That makes sense? So it makes a ligament of Treitz, I think. Is that what it is, Jimmy? I think ligament of Treitz. I can't remember. But what you do is there's 2 small arteries and 1 big vein. And the big vein is usually collapsed, and the arteries are kind of nice and round, right? Because they're thick-walled. What you want to do is cannulate the bigger of the 3 holes, right? One of these things is not like the other. Right? Whichever one stands out, that's the one you're going for. Okay? What happened? Okay. So, and sometimes they'll diagram it as a smiley face. You have 2 small eyes and a kind of a flat vein mouth, and you're going for the mouth. Okay. You want a clean cut if you're gonna need this. You want a clean cut. Don't cut down close to the belly because they're gonna want to replace it with probably a more sterile, longer catheter that actually becomes a central venous catheter and will actually ride up high in the neonatal ICU. Okay? So if I just want to utilize as little space as possible, it's a temporizing technique. Okay? This needs to be prepped very well with iodine. These can get infected, and it's called omphalitis. And you can take an infection that would usually be protected of the belly button and say, like, no big deal, right? But omphalitis essentially becomes a really bad infection because you've got a fast track right into the circulatory system, okay? So if I get this stump infected, you can end up with a really bad systemic infection shortly thereafter, okay? So I prep that very well with betadine. I use as the most septic technique I possibly can. You can use a small angiocath, cannulate the mouth, and that becomes your source. Sometimes you take a little tie and you tie around it, around the umbilicus to hold it in place. There's other ways to hold it in place too. But again, this is not, I would say this is not your first choice. Your IO is your first choice. If you run into trouble where you need access, this is how you do it, okay?
What's the typical size catheter that you use, and then what kind of confirmation do you have?
You should be able to draw blood. If you got a good seal, you should be able to draw blood off of it, and that's going to be pretty much your only confirmation, okay? So you should be able to draw blood. Withholding and discontinuing care, and then we'll take a little break, and then we'll come back and review some cases, okay? So withholding and discontinuing care, obvious ones are congenital deformities not compatible with life. Anencephaly is a great example, okay? Anencephaly is an incompletely developed head or lack of essentially central nervous system structures that make life possible. Our local regional cutoff for viability is 23 weeks, 0 days, okay? That equates to about a pound. Okay? Anything with fused eyelids is probably non-viable. That's kind of a good anatomic measure of viability. Fused eyelids or not fused eyelids, okay? Because that tends to transition right around the 23-week time frame, okay? They're going to have fingers, toes, everything else, very thin, thin, thin skin, but they'll have fused eyelids less than 23. This is a generalization, right? If in question, resuscitate, okay? If in question, resuscitate. Once you hit the hospital, and this is a conversation I had with one of the perinatologists and one of the high-risk delivery docs. Some of the guys who have been in the paramedic school have met her, Amy Okino. She came and did the labor and delivery talk, a little Italian, right? So she's... I call her, she's my reference for, and she delivered 2 of my kids. But so she's kind of the reference for me for local protocol. But she's the one who does all the high-risk deliveries. So she gets all these mothers who are delivering preterm and all that kind of stuff. And their cutoff is 23 weeks, 23 to 25. Really depends on family. They have lots of discussions. Is this something that you want to pursue? Do you want to do comfort measures only? So this is kind of a gray area. Anything beyond that, they are pretty aggressive with. Okay? Better to attempt when in question. In an APGAR of 0 at 10 minutes is a very strong predictor of mortality. So you get a kid who's 0 at 1 minute, there's hope. You get a kid who's 0 at 10 minutes, there is little hope. Okay? So that is a pretty good guideline to withholding and discontinuing care. That being said, all discontinued efforts or ceasing of efforts need to go through medical control. That's to protect you primarily. Okay? The other thing, too, is we don't do a lot of transporting resuscitations en route with adults, but remember that this is a atypical mortality situation. This is an atypical death. There are a significant amount of resources available to that family at the hospital that are not available at their home. And so I would have a low threshold to transport a neonate. And particularly because it's not the resuscitation effort can be contained to a single individual a lot of time, and I think it's more successful because it's just hands as opposed to bodies. And I think from terms of safety, you can still be restrained in the back of an ambulance and still be in a safe setting and do it. Okay. So I would consider that early transport reasonable, okay? Let's talk about cases next, but let's take a quick break, refill on your donuts, refill on your coffee, and then we'll go from there. Take an opportunity to tube, use the eye gel, IO. There's a small leg bone there. You can drill. Jim, so I took Lincoln camping. Did my dad tell you this? I took Lincoln camping. Where? North Fork of the Coeur d'Alene. We were just up there putzing around. And G5, P2, term gestation, mom is in active labor. Almost immediately after the first EMS unit arrives, she starts to crown, okay? During delivery of the infant, the anterior shoulder gets stuck, but is released with digital manipulation. So you shoulder dystocia that's released and the child's delivered. So potential delay in the birth canal, right? Initial appearance is cyanotic. The mouth and the nose is suction. Good tone and crying noted, but the face remains cyanotic and the skin is cool. Brachial pulse is detected, but the rate is uncertain. We talked about that. Pulse oximetry is not detected, and the 1 minute APGAR is 5. So what's your plan? So just take this clinical picture and tell me what your thoughts are, beginning at a G5P2.
Why G5P2? What happened to
What are the priors?
What happened to the priors, right? And the fact that she's got 2 priors, right? Because a primate, meaning someone who is never delivered, and they are crowning, or they're, I gotta push, they might be pushing for another hour, right? Someone who's pushed out a couple of kiddos, that baby's coming out, right? So knowing that is important. Plus the fact that we know this is a term mother. So what are my 3 questions, right? Oh, sorry. Want me to start over and fake it?
No, I
All right. So what are my first 3 questions, right? My first 3 questions, my 60-second analysis, right? I got 60 seconds to get my first ventilation on board if it's required. So what am I doing? 1, I know that this is a term kid, so that's a bonus, right? That's a plus. What's my next one? Tone. What's the tone on this kid? Good tone, right? What's my 3rd one? Breathing or crying. And this kid's crying, right? So even though I just got done delivering a shoulder dystocia, which is probably makes anybody a little bit anxious that doesn't deliver 5 or 6 kids a day for the last 10 years, right? Anybody who gets a stuck shoulder probably sweats a little. So that sets you up for anxiety, right? First of all, the call itself sets you up for anxiety because it's a delivery, okay? And then the kid's shoulder gets stuck, right? Now I'm really anxious, okay? This is a good opportunity to say, all right, I got a good kid, right? This kid is vigorous, it's a term kid, and they got good tone. They're crying, that's what I want. We can handle this one, right? So you see there are some concerns. What is your biggest concern at this point? Cyanosis. Heat loss and cyanosis, okay? So 2 things that we want to address in that first 60 seconds. Is this a kid that you should be ventilating? No, they're crying, right? They're crying out loud. They don't need to be ventilated. You see cyanosis, pulse oximetry, not detected, right? So what are you going to do? What's going to be your initial management to treat this kid's cyanosis? Warm them up, stimulate them, still crying, still persistently cyanotic. What do? A little bit of blow-by, right? So you've got what is set up to be a very kind of high stressful situation with a couple of things that have already got you a little bit amped up in the beginning, but then a few more things that are reassuring. And if you were totally ramped, totally primed, nervous, anxious, cyanotic kid, you could see someone throw a non-rebreather on this kid, right? Put 100% on them, right? They're still cyanotic. I don't have a pulse ox, right? Blow-by is totally appropriate. Totally appropriate, okay? 1 minute APGAR is 5. What about this? Brachial pulse detected, but the rate is uncertain. 3 lead, right? It's going to give me my most reliable indicator of that kid's pulse, and it's going to be my best indicator for successful resuscitation is heart rate recovery, okay? So that's your initial plan, right? So what does the kid get? Gets blow by O2. Blow by O2, 5-minute APGAR is 9. Kid comes into the hospital, looks like a healthy kid. Everybody probably assumes the kid looked great, just as good when they came out as they look at that time 5 minutes later, unaware of the fact that it was probably a little stressful in the beginning. I wasn't there, but when I read the chart, I'd be stressed. Uneventful hospital course, discharged home with mom, no ongoing medical issues to date when I looked in their chart this morning, okay? So, delivery of an entrapped anterior shoulder. And the technique was a 2-finger manipulation, right? Fingers in, you kind of corkscrew that shoulder roller, fold it over, right? You can corkscrew that kid and deliver that shoulder. Sometimes just taking the, where's that baby? Give me that baby. And I don't know if Pete went over this last month, but sometimes that shoulder will just stick and the mom needs a little bit of help. And if you take this kiddo in your palm and palm here, right, and you can just push that head down to the floor, right? Just gently push the head down to the floor and pop that anterior shoulder out, and then lift up and deliver the posterior shoulder, and the kid comes out, okay? Now, if it gets stuck, that 2-finger technique is kind of a corkscrew maneuver where you stick the finger inside the vaginal canal and you turn that shoulder and you can corkscrew them out, okay? But quick thinking on a kid who's stuck, and what do you think about when someone who's got a shoulder dystocia? What's your concern, right? Pressure on the cord, right? This is a kid who can't, when you're getting squeezed like that, you're not breathing. You've got pressure on the cord, right? You're essentially in this no man's zone where you can't transition from aqueous to non-aqueous successfully. It's not even, yeah, right? You're not an amphibian. You can't live there very long, right? So you got to come out and make a decision, okay? So that being stuck in the birth canal does lend to fetal distress if you're there too long, okay? So right off the bat, you're anxious about fetal distress. This was a great decision. Blow by O2. I had all the reassuring things that I wanted despite a stressful situation. I had all the things that I required. I probably have a bunch of other things I could do, but the most appropriate thing was done. O2, rapid recovery. The bulb suction in the nose and mouth. There's no mention of suction, but old habits die hard. That's one of the reasons this is in here, is everybody goes for a bulb syringe. If I delivered a kid today under stress, I would probably look for a bulb syringe. And I'd have to remind myself, I don't need the bulb syringe. Unless I have some indication of obstruction, airway obstruction. And then we'll suction those kids out. 3 lead, you guys caught on that too. 3 lead for pulse monitoring. And then temperature management. Bundle that kid up. No one's taking these kids unbundled and delivering them naked, right, to the hospital. Nobody's doing that. But we know that it is relevant in terms of prognosis. So indicate in your charts what you did to address that, because it is one of the critical things early on that can be done to improve outcomes, okay? So keep that kid warm. Describe what you did. Covered their head, put them in a little blanket, or put them in a blanket, wrapped them up, turn up the heat in the back of the ambulance, whatever. Okay, skin to skin with mom. Just put mention of it in the note because it's important. Any questions on this case? Good case, good outcome. Okay. Case number 2. This is a term home delivery with a midwife complicated by a shoulder dystocia also. They tried to manipulate something, felt something pop, and then delivered the kid. The kid is delivered through meconium-stained fluid. He's pulseless and apneic. Okay? Ventilation and CPR is initiated by the midwife and the father. The 1-minute APGAR is 0. And this is when the first arriving unit arrives on scene with the midwife ventilating but no CPR in progress. Okay?
What's the rate?
I don't have a rate. I don't have an initial rate. The kid is cyanotic. There is an audible heartbeat with a stethoscope, but no tone and no activity, and SpO2 is undetectable. Okay? So, what are my 3 questions? 60 seconds. Walk in the room. What do I need to know in 60 seconds? Term. No tone. Not crying, right? So, this is a kid in distress. This is bad. APGAR is 0 at 1 minute. This is clearly a kid that needs to be ventilated. Fortunately, they're being ventilated. Okay? If I'm doing CPR on somebody, what's the indication? CPR on an infant gets what? Intubation. Okay? So, by the fact that we arrive on scene after there's an audible heartbeat and no CPR going, I can understand why this kid is not intubated. But it should be on your mind, is this someone who we're going to be ventilating for an extended period of time? Or is this someone who is going to need ongoing compressions? And the first question you asked was what? Heart rate, right? And we already know, based on evidence, that it's hard to get a successful heart rate based off of SpO2, which is frequently unreliable in a cyanotic kid, and difficult to palpate. Okay? Make sense? So this is a little bit, we're up in the ante on this one, right? Okay? So, kiddo was bulb suction followed by a catheter evacuation of meconium-stained fluid. Okay? So, another indication for intubation is what? Delivery of a what child through meconium? A non-vigorous child through meconium-stained fluid. Does this kid meet that criteria? This kid meets that criteria. Okay? They get suctioned. I think this is an appropriate suction because I got an apneic kid, so I'm going to assume that this kid has got an obstruction. So I think suctioning in this setting is totally appropriate. They get BAV valve mask continued with supplemental oxygen. But en route, spontaneous respirations develop, and this kid is transitioned over to oxygen. The 5-minute APGAR is 7. Infant crying, they document a pulse rate of 150 en route. So it just goes to show how much ventilation is critical in this group. You take a kid that looks terrible, right? We have term going in favor for us. We have rapid initiation of ventilations. You could justify intubating this kid and saying, look, this is a kid who was non-vigorous through meconium-stained amniotic fluid. This kid's getting tubed. But this kid also has a very rapid recovery. In the next 4 minutes, I had an APGAR that went from 0 to an APGAR that's at 7. I don't think you could get your intubation stuff together in time to actually tube that kid before you looked at him and like, wait a second, this kid's breathing and I got a good pulse. So I think it's probably justifiable to say, okay, the kid looks like they're thriving and we'll watch them. Okay? What are your thoughts? Who would tube them? Who wouldn't? I think that's probably to be expected. I think the vast majority of people would not tube this kid. One, because the kid got better fast enough that you could probably get your stuff together to tube him, right? But there are indications here to intubate. Fortunately, the kid did well. I have no question in my mind that if this kid did not recover, the kid would have gotten intubated. No question in my mind. I think he recovered so quickly that he was allowed to proceed without. So he gets admitted to the NICU. He's vigorous on arrival, as noted on the ER note. He's got a left humerus fracture that repaired fine, or that was did fine without surgery. He got discharged home after 1 week, and according to his 4-month welled child visit, he was a healthy infant without significant medical history, no complications, and he did well. Okay? So, good outcome on a kid that was APGAR of 0.
That humeral fracture, is that?
I'm not sure what happened. They must have like grabbed the arm and tried to pull it out.
I'll tell you what happened, because this was my kid. So
I do my best to keep this
I
anonymous.
know,
but-
that's fine. No, home delivery, it came in as a newborn, non-breathing. When I got in the computer, it said midwife was still on scene, so I mean, this was a newborn, you know, and we walked in there, she was bagging the kid. The kid was purple, not even blue, it was like an eggplant, and it was just purple. And so I went right to the midwife and I asked her, what do you need me to do? I figured she's kind of the authority at this point, so I asked her, and she says, would you listen for a heartbeat? I said, yeah. And a strong heartbeat, I could hear it, but the kid was not breathing at all. And she says the kid had been stuck for a long time. They couldn't get it out. Dad got a little zealous and he yanked a little hard. And they said, we heard a pop, so we think we broke the shoulder. Dad broke the shoulder. So I said, well, all right. And the dad was all upset about the shoulder, and I said, I don't care about that right now. That was beside the point. And I asked her at that point, I said, you suctioned, I'm assuming you suctioned, because there's nothing happening at all. This kid's not even trying to breathe. She says, I did, and she reached over and grabbed the bulbs and tried again and not really got anything. I said, I have some mechanical suction. Would you like to use that? She goes, yeah, let's do that. So I took and I put the catheter on there, reached in there, and we were actually sucked out a couple good chunks right out of the throat and stuff, and then she started bagging. And then it just slowly had a squeak here and another squeak and a grunt, and it just started coming better and better. The placenta hadn't delivered, so we're still, mom's on her hands and knees under a blanket, and the dad wants to cut the cord, and the midwife's saying, no, not yet, let's just leave it for a while. And we just kept working and working and working the breathing, heartbeat stayed good, and the kid just started off suddenly, it just kept ramping up. Skin got better, color got better, until we felt really comfortable with going ahead and then cutting the cord. And I had everything in place to be able to load the kid right away on the PD board. And mom said goodbye, and now we went. So.
And that's part of the reason I know that if the kid needed to be intubated is because I know who the provider was on scene, right? So it's easy for me to say, the kid needs to be intubated, I know the kid's going to get intubated. So you could play Monday morning quarterback and say all day long, this is a kid that was non-vigorous going through pneumonia stained fluid, right? But the truth of the matter is, the kid is doing well because good decisions were made. And I think at some point you got to make the decision, right? Make the decision, you make it the right decision. So I don't have any concerns based on this kid not getting intubated, because if they really needed it, I know they would have got it. How did you see meconium, Tony?
What's that?
How did you make the judgment on meconium stained fluid? Is that what she told you, or did you see green?
You know, I'm trying to remember exactly. There was stuff everywhere. I think it was just more concerned I didn't think that bulb suction was, I wanted better suction, and to see if there was something else in there. And as soon as we popped something loose.
Did she say that it was meconium stained amniotic fluid, or did the kid have like green vernix on him, or what was the indication that made you?
I don't remember.
Okay.
I just know that they were still sitting in the bed with all the goo was there of everything, and I don't recall.
But a good case of a neonatal resuscitation, and it just goes to show that kids that look really poorly can respond very well to basic airway ventilation management. Okay, they responded very well to it. In this kid, someone who even got compressions, but again, a good outcome. Okay, so something to celebrate. A job well done on that one. Okay, case number 3. 23-week gestation, delivered into a toilet at home. CPR was initiated by the mother at the direction of dispatchers. On scene, the kiddo is unresponsive, cyanotic, apneic, pulseless, and the skin is warm. So, 60 seconds. What's your plan? What do you got? Your 3 questions. Preterm, bad. No activity, no tone, right? Bad. No breathing, bad, right? This is an APGAR of 0. My 3 questions, this is bad. First step is what? This kid is going to get ventilated and CPR, right? Because I have a heart rate less than 60, because I have no heart rate, right? So they're going to get the 2-hand circling technique with ventilations and targeting what? 3-1, 3-1, 3-1, 3-1, 3-1. Asynchronous 3-1, 3-1, 3-1, right? Right? Is that the right word for it? Where I'm not competing. Breaths are not competing with compressions, okay? What else in this kiddo? Let's just kind of cover all the bases. Preterm care, right? or initial immediate care? What are my big concerns? Get them dry, get them warm, heat loss. What can I do in a circumstance like this? What are some of my options to keep this kid warm, particularly premature infants? Get them and put a plastic wrap on them, okay? Particularly in preterm infants, the clean food grade plastic wrap, which depending on how small they are, could be saran wrap, could be a Ziploc, clean Ziploc, it could be any number of things, but a clean wrap and a barrier around that if possible, okay? You can do compressions through plastic bag, right? You can see ventilations through a plastic bag. Obviously, we're not tying off the top and delivering them, right? But it at least gives me a barrier there, okay?
Do you warm towels, put them underneath, use a...
Yeah, if you've got something to swaddle that kid in, one, I'm going to dry him off. I'm going to get something around them. In a preterm kid, particularly, that plastic helps. And then I'm going to put another insulating barrier around them. Obviously, I don't want to try and do my compressions through it, obviously. But if I can get something underneath them that's warm, around them that's warm, cover the head with something that's warm so that I can actually keep the kid at an appropriate temperature.
How big of a deal is the food grade plastic?
What if it's not food grade plastic? I'm reciting American Heart Association guidelines. If it's my infant, I don't care what plastic it is, as long as it wasn't used to poop scoop the day earlier, right? I mean, anything that is a clean plastic, I think for medical legal reasons they have to term it food grade plastic, right? Otherwise the FDA is going to not let them say that or something like that. I don't know. So, but a clean garbage bag, right? I wouldn't dump the garbage out and use that one, but I'd get a clean garbage bag, right? That's a nice, good plastic clean barrier. Are you going to intubate this kid? How are you going to intubate this kid? What size tube would you use on a 23-week gestation kid? I think I'm not sure the Broslow tape goes this. Does it go this small? This is a kid that's about this big. 2.5. Who says 2.5? Who says 2.5? 3 is generally what you do your term infant with, right? You go to a 3, right? Generally, based on your little rule of the little equation, usually rolls out at about a 3. So 2, 2.5, I think that's probably a good starting point, okay?
Doc, is this a viable because of the age? I mean,
Right, it's questionable. Right, 23 weeks is right at the cutoff, right? So viable or not? It doesn't say. It doesn't say. But I think according to the neonatal response and the hospital course, I suspect that they were open and it happened to be 23 days or 23 weeks and actually like 3 days. So it pushes them into the, so they went for it. And I think it goes to show if I'm going to err on the side of caution, then I would go for it. Yeah.
This was my call.
Okay.
So I don't remember if the eyelids were fused, but they were not open.
You were too busy trying not to mess your shorts, probably. Yeah.
Yeah. So we swaddled the baby, dried him off,
Mhm.
began CPR and DBMing.
Okay.
Cut the cord on scene and got going as fast as we could.
Did you consider intubating?
We considered it, but we kind of agreed to, in order to go as fast as possible, that
Right.
we were just getting into the back and going.
Okay.
The baby was taking BBM respirations very well.
Mm-hmm.
And I remember seeing the baby and being shocked at how small it was.
How small it was.
So like
Not
we,
something that was like, yeah, I'm tubing this thing.
we didn't even think that
No
we had a
question.
tube that would have worked.
Yeah.
It was so small.
Tiny.
And because it was taking the bag and respirations well, we got good chest rise and we could hear movement. We just did that.
Okay. And I think that's very reasonable. Very reasonable. You know, I would be less than excited about attempting an intubation on something half the size of this mannequin. You know, it's just not very inviting. And if I felt like I was ventilating well, I might do the exact same thing you did. Now remember though, in the protocol, one of the indications for endotracheal intubation, one is chest compressions of the process and very premature infants. Okay? So the indications were there. So you've got to say, do I go for it? Or do I have a good reason that is based on sound medical decision making that I didn't, right? Or was I just like, look, we got to get the hell out of here and go fast, right? But then you got to get into the dilemma of what's the most appropriate thing to do, what are appropriate scene delay procedures. Securing an airway, some would argue absolutely is one. So something to think about in this case. And I don't think you could get everybody in this room to do the same behavior if each one had. I think you would get some people would try and intubate. I think most people would be unsuccessful at intubating for one, right? And you'll see that they struggled, even in the neonatologist struggled with intubating this kid. But I think you would get a mixed bag of responses. So I think it's easy to be a Monday morning quarterback and say, you had an intubation indication, why didn't you do it? Well, for one, this thing was tiny, and I'm not sure I had a tube that could fit in there, and I didn't want to sit on scene with this infant, right? Then that seems pretty damn reasonable to me. But if you said, I want to give it a go and I want to look, the indication is there. But I think you got it when you get in these circumstances. This is why I encourage you guys to do medical decision-making caveats in your charts. A naked chart leaves you quite vulnerable to criticism, right? A little caveat, we consider intubation. This was a very small infant. I did not feel like we had equipment that was appropriate based on the level of prematurity. Then it tells me when I read that chart, they thought it, they considered it, they made a decision based on sound medical decision making. I can support that. Make sense? You want to say something?
I had this exact call 20 years ago in on paramedic school.
Yeah.
I mean, exactly. We couldn't anatomically see
Yeah.
anything
Oh.
down there when we tried to intubate it. There was nothing, there was no landmarks, there was nothing.
Couldn't see.
It was very bizarre.
Yeah. Yeah, and that's probably what happened with the neonatal resuscitation team. So here's what happened. CPR is continued by initial responding unit. There's a document that they feel a pulse in the cord with compressions. They're doing mixed, it sounds like mixed oxygen, not blow-by if we're BVing in, but mixed oxygen concentration, which is appropriate for an infant. Not you could do 100% since we're doing compressions, but it looks like this blow-by documentation is kind of inconsistent with the initial BVM. Unchanged status during transport. They get into the ER. They do an umbilical catheter. They give the kid epinephrine 5 times. He gets D10. He gets intubated on the 3rd attempt. 2 failed attempts. Actually, 1 attempt that failed. The 2nd attempt that dislodged, and then they had the reattempt. And this is 3 neonatologists. So I'm not sure what the success rate would be for people who, that's the only time. I've never intubated a 23-weeker. I can't tell you how successful I would be. I would say my odds are probably about as good as the Mariners are batting right now, which is pretty lousy, okay? Temperature 34.4. They did rewarming efforts. It sounds like you guys did rewarming efforts too, gonna get him bundled up as much as you could. His course is complicated by sepsis, bilateral intraventricular hemorrhages, ventilator dependence, and then I think it could be expected on that gestational age. Family withdrew care at 14 days, and the kid expired almost immediately after that. Okay, but this is a tough case, right? You show up on scene, this tiny little thing, and you make a strong, valiant effort. The truth of the matter is, that's a losing battle 9 times out of 10. But I think it's a good one to practice that, to think through it and say, 60-second rule. What are my 3 questions? What is my first response? Did I start ventilations within the first 60 seconds? If I'm doing CPR, am I doing it appropriately? Do I need to get IVO access? Do I need to try and intubate this kid? Is this someone clearly where a rapid transport is favorable, because I don't want to sit here and play on scene with someone as complicated as this? I think it's very, very good case to discuss to address all those things. I think that's fair, Will. I hope that didn't come across as too harsh.
No,
Fair?
I definitely feel like I should have looked in retrospect.
Yeah.
But at the time, not thinking clearly and looking at the size of the kid, we didn't think that we could have done it.
Part of the other reason I like to review these kind of cases is these are tough cases to take home with you at the end of the day. You know what I mean? Even ones where you say, look, the odds were stacked against us. It's still a kid, right? And I think it's good to review these cases for just a sense of getting it out there. It's like why Catholics go to confession, I think. You know, you just kind of got to get it off your chest and you feel better afterwards, right? So there is some benefit in just this, the use of a situation like this, as high stress as it was, how to kind of pull some closure together. So I think this is a valuable opportunity in that. I don't know how your crew took it and how you guys kind of managed it and filed this away in your life file cabinet. But I'm hoping that opportunities like this will help. Okay. Case number 4. This is a G2P1 28-week preterm delivery at home. The mom is found with the mother, or the infant is found with the mother, who has a history of IV drug abuse, and an opioid toxidrome is present on exam. From my understanding, it was a pretty depressing scene based on the appearance of the mother, who later admitted that she had injected oxycodone to deal with the pains of labor. No prenatal care, admitted to no prenatal care. So I got a preterm infant delivered into the arms of delivered into the basement of a house that was quite disheveled, my understanding, to a opiate intoxicated mother. But despite that, by the time we got there, we had an APGAR that sounded like it was a little beyond the 5-minute mark of 6, so a questionable kiddo who's got an absent cry but steady respirations, a pulse of 120 to 126 with an ECG monitor, a blood glucose of 94, and commented the majority of efforts spent keeping infant warm and electrodes in place. Okay? So, what are my 3 questions? Obviously, this is not at the time of delivery, but what are my 3 questions? Am I term? No, this is a preterm kid. Okay? What do I have for tone? Sounds to me like the kid probably had some tone, but definitely not a vigorous cry, but some steady respiration. So I'm kind of in that, this is a really bad scene. I'm expecting something to be bad here. I've got some reassuring signs. I have a lot of unreassuring signs. So you're still kind of in that limbo. You know you're dealing with the high-risk infant. Okay?
Mom's tone probably wasn't that great either, considering.
Yeah, you got a mom who's just overdosed
So
too.
are we looking at a kid that is also high, or are we
Right.
looking at a kid that is?
Well, the other consideration is, if I have a poor respiratory response in this kid, right, is that because the kid was apneic, or is that because the kid's high on oxycodone, right?
I know it.
Right, so while Narcan is not indicated routinely, this may be one of those situations where you say, look, I've got a persistently respiratory depressed infant who has an exposure to an opiate and a mother with an opiate toxidrome. This may be a time to consider Narcan, right? I would not be dumping Narcan on this little kiddo because I don't know enough about Narcan in infants, but I would definitely consider it, and I think it would be worth a call. Medical control, here's what I got. I got a mother who's high as a kite, opiates. I got a kid who's respiratory depressed. I'd like to give a little bit of Narcan. I think it's very reasonable. Or I'm gonna give a little bit of Narcan. We'll see you in 5 minutes, right? If they say, no, 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 then, well, I guess I didn't get it. But if they say, okay, sounds good, there's your blessing, right? It's all in how you word it. You gotta be careful. Jim, this is what I tell them. It's all in the wording. Just a
Excellent.
So, a difficult situation. What are your other considerations here?
I was on that call.
Right.
I was the third paramedic on scene. I never made it into the basement, but I was told it was unpleasant.
Right.
Mom showed up to her mother's house 3 days earlier. Grandma didn't know daughter was pregnant. We were told possibly 23, 24 weeks gestation. Didn't know.
Right.
When they finally bring baby up the stairs into the ambulance, bringing mom up at the same time, we don't have a second ambulance ready. Everyone piles into one. And I've got one paramedic taking care of baby. That was thanks to our friends from AMR. I've got one paramedic from City Fire. His name is Brian Schaefer. He's looking after mom.
Another complicating variable that they don't frequently.
Chief Schaefer's looking after mom. AMR paramedic's looking after baby. My firefighter is the scribe with a piece of paper down the middle, with a line down the middle that says, write this down for mom, write this down for baby.
Yeah.
And I was the right-hand man for treatment left and right.
Right.
The majority of effort spent keeping infant warm was a big deal.
Yeah.
Quite honestly, I don't think we had time to consider Narcan.
Yeah.
It was, let's just
Let's go.
down the road.
Okay.
Keeping the electrodes in place was difficult because everything was just sliding off. So
Yeah.
it was hold, good heart rate, yep, keep them warm, let's go.
Okay. How difficult do you think it would have been to get a pulse, an accurate pulse without those?
Wasn't happening.
So I think that's a good point to take away from this one is the use of the 3-lead monitor. Because it tells you in a kid where you're kind of in a questionable circumstance, how good am I, where am I at? I'm kind of, everything's giving me kind of this mediocre. I'm not getting a whole lot of reassuring signs, but I've got some there that's telling me the kid might be okay. What's my best indicator? Pulse. This is a good circumstance where a nice, reliable pulse can give you a lot of reassurance that things may be heading in the right direction. Okay?
Respiratory rate was staying in the 40 to 50 range as well.
Were you doing any blow-by, or was this kiddo room air?
It was room air. We had blow by when we could hold it, when we weren't holding electrodes in place.
All right, so the kiddo gets into the ER with a temperature of 36.9, which is good. Mom admits to injecting oxycodone to address her labor pains. She admits to no prenatal care. She was also chlamydia positive. And she had a drug screen positive for methamphetamines, opiates, and methadone. The kiddo got put on empiric gentamicin and ampicillin. And actually, chlamydia is one of the delivery and mother with active chlamydia is one of the highest rates of childhood blindness in the world because of the infection. That's why kids come out and every kid gets the antibiotic ointment in their eyes, right? You ever notice that? They are just assuming that your significant other has chlamydia at that point, all right? But that's what it's for, because it is the highest rate of childhood blindness is related to untreated chlamydia infections in the infant. So they get the whatever antibiotic in the eye. This kid got it taken care of, tolerated oral nutrition, was monitored in the NICU for neonatal abstinence syndrome. Turns out the kiddo was about 32 to 35 weeks gestational age, and ultimately was discharged home in good health, doing well, with foster parents at day 21. The mother was when I kind of was following this shortly after it happened, the mother had gotten into treatment. She was regularly visiting the child in the NICU. Was enrolled in a treatment strategy. Clearly had very poor coping skills that were kind of noted throughout the chart. And then I lost her to follow up. So I don't know how well she did, but it seemed to have triggered some maternal instinct to clean up and I hope that she still did well. But the kid appears to be doing well from a health standpoint, and in his foster care at this time. Okay, right on time, look at that, 3 minutes to spare. Any questions at all about neonatal? Yeah?
So I know Sacred Heart is the best place to go, right? In these cases, is it really the only place to go?
Deaconess has a neonatal intensive care unit.
Okay, fine.
Deaconess has a neonatal intensive care unit, but they don't have a pediatric emergency department where this kid is going to go initially. Most neonatal care units are there to take kids from the delivery suite to the NICU. So if I had a preterm delivery or a home delivery that is a kid that's going to need to go into neonatal care, I think the resuscitation effort by the pediatric ER trained doc would be preferred, but in reality, they call their neonatal team to the ER and they essentially run the code. So I think Deaconess or Sacred Heart are reasonable transport destinations.
So if we've got a case like the one where we're not going to get them intubated, we're trying to get her as quickly as possible, and we're out in the valley, should we go past Valley Hospital and come down to Sacred Heart or D, or should we go to Valley? We haven't been able to get